Waiting on our last speaker, folks. Dr. Raskin is our last speaker, and we're waiting on him to log in so we can get him connected and get him to share his screen. So we are on our final speaker once he presents. And actually, while we're waiting on him, I'll just make a few little announcements about our ISET membership and ASET membership from our website. So if you go into our new website, there's an area where you can go to members, and there are two tabs. Once you scroll down, you can, if you want to become a member of ASET and ISET combination, there's a tab you can click that will take you directly to the ASET website. If you just want to become a member of ISET, which is the Indiana Society, obviously, you can click that tab and it will take you to a page there that will allow you to pay for that membership. And that's through a PayPal account that we have. And so I encourage you, if you do like what you've heard today, this presentation, we are going to be going towards this platform. Hopefully we can get back together in person for our fall meeting, but regardless, we will be presenting this in a webinar version as well. We would love for you guys to join us as members if you are not already. So I'm not sure if we have Dr. Raskin on yet, Lisa. Okay, there he is. So I'm going to stop talking and let Lisa introduce him. Thank you, guys.
All right. Thank you, Erica. All right. All right. Well, we are all familiar with the life-saving and life-changing modality of neurosurgery and the impact it can make on our patients' quality of life. Be it a spinal surgery or a brain surgery, these cases are fascinating and a heroic part of our field. And today, we have a special opportunity to look into the specific world of surgical strategies for pediatric epilepsy. Joining us is Dr. Raskin, a pediatric neurosurgeon at Riley Children's Hospital. Dr. Raskin's passion for neurosurgery was ignited early in his studies, as his undergraduate degree is in neuroscience, which led him to a residency at the Oregon Health Science University in Portland, and his fellowship training at Texas Children's Hospital and Baylor College of Medicine in Houston. During this experience, Dr. Raskin found pediatric neurosurgery to be an especially rewarding area of practice, and we are very fortunate that he did, as he has helped make a difference in so many young people's lives. Thank you, Dr. Raskin, for joining us today, and I will give you the screen.
All right, great. Hey, there's my big face. I can see it. Okay, let me share my screen here. Okay, can everyone see that? Can you see that? Perfect. Okay,
Yes,
thank you, Lisa, and the scientific committee for inviting me to give this talk. I'm a pediatric neurosurgeon at Riley. My main specialty is functional neurosurgery, which includes epilepsy to a significant extent, as well as pain surgery and movement disorder surgery. And so I like to start by saying I have no disclosures, of course, and acknowledging everyone up front in case there's no time at the end. Of course, everyone who pays me and all my patients, and then in particular, the Indiana University neuromonitoring team, Haley, Sarah, Michael, and Eugene, who are just absolutely spectacular, extremely professional, and I love working with them on a weekly basis. So thank you guys all for your dedicated work, and to all of you for your dedicated work during this crazy public health crisis. The syllabus is pretty straightforward today. I'm going to talk about three main areas: what medically refractory epilepsy is and how we come to diagnose it, some therapeutic strategies, and then in particular for all of you neuromodulatory minded folks, neuromodulation for epilepsy and its brief history and what we do nowadays. So I haven't been privy to what has already been discussed, so some of this may be repeated, but that notwithstanding, I'll get started here. Basically, I'm trying to move this duder. Okay, basically, epilepsy is, of course, a seizure disorder where a seizure is defined as a hypersynchrony of neuronal discharge. That hypersynchrony of neuronal discharge is abnormal. Neurons should be communicating in a pathwise process and not all discharging at once like an electric eel. The treatment goal as defined by the International League Against Epilepsy is no seizures and no side effects. However, we know that despite multiple medications, a good 30% of population with epilepsy will be refractory, meaning that they are untreated and they continue to have burdensome seizures throughout their life. And those are the patients that qualify for seizure surgery. And we know that in particular in children, ongoing seizures and the medications intended to treat seizures profoundly affect the developing brain. Epilepsy dogma involves the identification of an epileptogenic zone, which is, as I've already said, a group of neurons that discharge with hypersynchrony. And those are defined, that area of cells, substructurally and pathophysiologically by excessive neuronal synchronization caused by maybe proliferation of nicotinamide and acetylcholine receptors, overall increased glutamatergic transmission and decreased GABAergic transmission. And then those epileptogenic zones can recruit distant neuronal networks and give rise to a network. And that network is what we're trying to deconstruct by, one, identifying it, and two, removing, disconnecting, or neuromodulating the epileptogenic zone. So that is the whole thought process behind seizure surgery. And it turns out that it's really difficult to understand exactly which cells are synchronized and causing the seizures themselves. And we use a variety of techniques in a phased workup. And that phased workup has 4 phases. Probably someone has talked about phase 1. That's the most important phase. And that includes a history and physical, a video EEG, which you all facilitate, structural and functional imaging, and a neuropsychological evaluation. And that's defined. That's the defined phase 1 workup. Anything less is not a phase 1 workup. It's part of a phase 1 workup. So phase 1 workup sometimes leads directly to phase 4, which is all of the therapeutic procedures, including resection, disconnection, modulation, and ablation. But sometimes phase 1 leads to phase 2 because that information is discordant, meaning it doesn't all go together. The whole point of phase 1 is to understand, number 1, does the child have epilepsy? A good 20% of patients referred for video EEG actually will have a movement disorder or myoclonus or a psychogenic seizures. And so it's very important to understand whether or not the child has epilepsy, and then what type of epilepsy, what is a possibility of remission, is surgery warranted, and if so, what surgery? And then importantly, is the child and family prepared for the psychological impact of surgery and it being effective or sometimes not as effective? And when all the phase 1 data is what we call concordant, meaning it all points to one location, then we proceed with some sort of surgery. In this case, frontal lobe hyperintensity there would be resected with good result. And again, the phase 4, the therapeutic interventions are resective surgery, disconnective surgery, neuromodulation, which I'll go into some detail at the end, and ablative surgery, which is more innovative. But in children in particular, they tend to have extratemporal lobe epilepsy, meaning that their seizure onset is not on the temporal lobe like most adults, but it's somewhere throughout the brain, and that's much more complicated. They also tend to have multiple focal onsets or ictal genesis zones, and that is even more complicated. You can imagine trying to find one ictal onset zone is hard enough. Now, if there's a network of ictal onset zones that can generate independent seizures, it's very difficult to treat. And some of those children's brains look like these. On the left, you have paraventricular nodular heterotopias. You can see studying of the ependymal lining. It's very abnormal and seizurogenic, and impossible to understand from the outside of the brain where exactly that seizure is being generated from. In the middle is a hypothalamic hamartoma, one of the most seizurogenic lesions that we know of. And on the right is a child with tuberous sclerosis with T2 signal throughout both cerebral hemispheres, very high tuberal burden, and those children as well, very difficult to tell where seizures are coming from. They can generate new seizures over time. So these children need what's called a phase 2, which includes intracranial electrodes. Intracranial electrodes come in really 2 flavors. One is subdural grids and strips. You can see that on the top left. That involves a craniotomy, sweeping incision, removing bone, putting the grids and strips on the surface of the brain, under the frontal lobe, in the interhemispheric fissure, but basically sampling the surface convexity of the cerebral hemisphere. Whereas phase 2 with stereo EEG, which are the other 3 iterative pictures there, show different approaches to doing more minimally invasive, or what we like to call minimal access surgeries, where you place depth electrodes, in some cases orthogonal, meaning directly perpendicular to the skull into the brain that needs to be sampled. And on the right is what we do, which is, you can see there's more heterogeneous spacing between electrodes. They're at oblique angles, and those are generated based on the phase 1 data specifically. We call that dynamic stereo EEG, and at Riley we have the only robotic stereotactic assistant robot called ROSA in the state, and apply this technique, which we learned in fellowship and applied here to now about 20 patients with good results. So that's it about medically refractory epilepsy. I think in summary, these are children who more likely have extratemporal lobe epilepsy than not, with multiple onset zones, very complicated kids, and it represents about 30% of patients with epilepsy. So we'll move on to therapeutic strategies. Resective surgery has the longest history and is probably the most effective. It includes lesionectomy. For example, if there's a little tumor, that tumor can be removed, and probably the epileptogenic zone around the tumor. And those patients go on to have very high seizure freedom rates, upwards of 90%. Lobectomies, most likely temporal lobectomy, which is the case I'm about to show. Temporal lobectomies are extremely effective, 70 to 80% seizure freedom, depending on what papers you read. But nonetheless, 70% seizure freedom for a child who is medically refractory is a very good surgical outcome with pretty minimal morbidity. And then quadrantectomy is something a little more rare. It's where you disconnect a quadrant, for example, where the temporal, parietal, and occipital areas come together. Is called the TPO confluence. And sometimes seizures originate there, and we can actually transect that little area off, leaving it in place or removing it depending on your goal of surgery. So this is we're going to do like a case-based understanding of some of these therapeutic procedures. This is going to be a temporal lobectomy. So this is a 14-year-old female with left mesial temporal sclerosis. Age of onset was somewhere between 1 and 4. Sometimes that's hard to determine exactly. Child did have 2 febrile seizures, but started having unprovoked seizures at age 7, and that's bad. That's pretty much when the seizure network has become strong enough to just produce seizures without any provocation. And those are always medically refractory and needs a phase 1 workup and probably a seizure surgery. The seizure description is there as complex partial seizures. Past medical history includes being born premature by C-section in the NICU. No metabolic testing. Child was noted to develop normally, although neuropsych shows right language dominance, and the child does struggle in school and has an IEP. This is typical of what we see with these patients who become medically refractory as far as anti-epileptic drugs go. Child is currently treated with multiple medications, including valproic acid, oxcarbazepine, and Onfi, and has failed multiple past medications, including Dilantin, Lamictal, Topamax, Keppra. LOE means loss of efficacy, meaning that you start it, it's like effective, everyone high fives, you're like, yeah, this is the magic bullet, but then of course it's not. And so that's very common. This EEG, spot EEG, this was a video EEG. This is just one frame of electrographic waveforms showing onset at F7 and T3, and then somewhat at F3, indicating left frontotemporal onset in the anterior and mid-temporal areas. And here's the MRI. Of course, it's reversed, so I don't know if you can see my mouse here, but this is the left hippocampal structure, and this is the right hippocampal structure. You can see the left hippocampal structure is quite bright compared to the right, and it also doesn't look like a jelly roll. This one the right side looks almost perfectly like a jelly roll. And on the left side, of course, it's bright and it doesn't have the cyto architecture that you expect of the hippocampus. PET scan over here shows purple left temporal lobe. And purple means that it's hypoperfused. So here's a physiologic study paired with an anatomic study, paired with the EEG, all showing that it's coming from the left temporal lobe. We call that concordant. And then This is the fMRI demonstrating significant right-sided language dominance and really no left-sided language dominance, particularly not in the temporal lobe. A summary of this child indicates that there is concordance between ictal, interictal MRI, and PET of the left temporal lobe, and this patient goes to surgery. Just as a side note, this workup took 2 months, which is pretty fast for a phase 1 workup, and occurred at age 14, 7 years after she started having recurrent seizures. So that's not so good. It's better to have these children present within 1 year of refractory epilepsy, and your results are much better. However, this child proceeded to have a very good result. Surgically, this is, you can see resective cavity here. This bright white is just all spinal fluid. Right side is preserved. You can see superior temporal gyrus preserved with white matter. That's a critical surgical capability you want to maintain. And then we go back in the temporal lobe resection to the lateral mesencephalic sulcus, which is right here. So pretty good result surgically, and the child went on to be seizure-free and still seizure-free. And then over time, the epileptologist will wean those medications as able. Hopefully they'll be, perfect result would be off medications, no side effects, no seizures. And now we'll talk about ablative surgery. This is a more innovative approach. SLA is stereotactic laser ablation versus focused ultrasonography. Focused ultrasonography is just starting to be clinically available, mostly in the treatment of movement disorders, but doesn't involve any incisions whatsoever. We don't have that here yet. It's research heavy in children, not really indicated clinically, but hopefully we'll get it here soon. Stereotactic laser ablation I'll talk about. This is cool. It's the application of laser therapy through little 3mm incisions, and I'll explain it. First, with every technology trigger, it goes through what's called the Gartner hype curve, which includes a peak of inflated expectations where we just apply it willy-nilly to whatever because it's really new and fun. And then you unfortunately fall into the trough of disillusionment where things aren't working out like you expected. I think that now we're probably in the slope of enlightenment and not yet at the plateau of productivity. So that's good. Stereotactic laser ablation is a minimal access surgical strategy. It works by placing these lasers that you can see on the right into a surgical corridor, through a surgical corridor into a lesion. You turn that on in the MRI scanner, and that light energy is converted into heat, destroying the tissue that you want to destroy, while the software allows you to protect some of the critical nearby structures that you don't want to destroy. And this is known as laser interstitial thermal therapy, or LIT. And the goal is to convert, sweeping open craniotomy, as you can see up here with major resection, into a little bolt. And that's, obviously, from a blood loss perspective, from a pain perspective, and so on and so forth, much better. And this has been shown with safety studies that it leads to a shorter hospitalization, less discomfort, and less postoperative pain. The laser is a 1.65mm laser, which is extremely thin, especially compared to any other surgical instrument that you might place through the brain. And you can achieve surgeries just like temporal lobectomies. So for example, in the setting of mesial temporal lobe epilepsy, which is not what that other patient had, but mesial temporal lobe epilepsy, specifically associated with mesial temporal sclerosis, you can actually place a laser from the back along the long axis of the hippocampus, and then incrementally pulling it back, you can burn the hippocampus itself while you spare the rest of the temporal lobe. And this has actually been studied and been shown to lead to decreased verbal fluency deficits in children and adults. The seizure freedom rate, not as high. So this is a study I did as a fellow where we looked at the world literature and understood all the different cases that underwent laser ablation for temporal lobe epilepsy. And it turns out if you have mesial temporal sclerosis, then your 1 year angle class 1, which is totally seizure free, is about 67.4%. And if you have mesial temporal lobe epilepsy with or without a lesion, it's about 62.8%. Compare that to open temporal lobectomy, where you're taking out the mesial temporal structures, including the hippocampus, the dentate gyrus, and the amygdala, versus laser ablation of the mesial temporal structures and resection of the neocortex, in that setting, you have actually much higher seizure freedom rate, about 70 to 80%. So you're giving up a little bit of seizure freedom rate by doing a minimal access surgery. But of course, the minimal access surgery is overnight in the hospital, home the next day, you know, and you can do it again and again. It doesn't prevent you from doing the larger surgery up, you know, in the future if you need to do the larger surgery. And this is being studied with now a prospective pivotal trial called the SLATE trial, stereotactic laser ablation in temporal lobe epilepsy. Hypothalamic hamartomas, these are the most seizure-genic lesions that we have, often associated with gelastic seizures, which is this laughing seizure. Also, some people don't know it's associated with a dacrystic seizure, which is a crying seizure. They both involve activation of the fasciculus retroflexus, which goes from the posterior part of the hippocampus down into the brainstem and activates all of the neural mechanisms that involve laughing, but without the feeling. So it's called mirthless laughter, is a gelastic seizures, and it's kind of creepy. Little toddlers will go, but they're not like smiling at all. And they can do it, you know, 100 times an hour. It gets very disruptive and is a seizure and limits normal integration of biological processes and development of behaviors. This is a child we did here. You placed a laser, as you can see in the top right, from parietal eminence down through some pretty critical structures, but again, it's only 1.65 millimeters, so you can get away with that. Apologize for that. And then once you have this in the operating room, once you place the laser in the operating room, in the middle of the hamartoma, which you can see here, then you go to the MRI scanner and turn on the device. This is a T1 post contrast, and what you see here is the blood-brain barrier disruption surrounding the thermal injury. And these are very critical that you keep the thermal injury to the hamartoma and you do not let it extend into, for example, a cerebral peduncle or the normal hypothalamus. And this is what it looks like. This is an 18-month-old, another hypothalamic hamartoma, but you can see this frame-based strategy in order to get very submillimetric accuracy into the hypothalamic hamartoma through very critical structures. This is not an easy procedure technically to perform. It involves integration of an O-arm here. It involves integration of an MRI, laser surgery. This is something that only tertiary, quaternary level places can perform and is maybe the culmination of the coolest technology we have to treat epilepsy. This is another example of insular onset seizures. So this is a child I previously operated on who has a WHO grade 2 low-grade glioma and seizures. I published this case in Child's Nervous System. You can see here that the tumor is in the insula. It's in the posterior part of the insula. The family was counseled that we could do laser ablation, you go home the next day, or we could do transcranial approach and, you know, get it all. And they wanted a transcranial approach against my advice. So we did this transcranial approach. You can see a craniotomy here, and I got into the tumor and removed a bunch of it, but it grew back. Child was almost immediately had recurrent seizures. So we did a laser ablation. You can see the thermography starting down here. This is what you actually see in an MRI scanner. I would turn on the laser here and see a heat map and understand what I was destroying. And as the thermography or the thermogram is changing, you get deposition of this orange pigment on the right. And this is called the thermal damage estimate. And then these are the two end results when I was satisfied that I had done the extent of the surgery. At surgery, you might see this. This is a flare post-contrast. So you see the blood-brain barrier disruption around it at surgery. And at surgery, I would have protected the putamen here. That would have been the critical structure to protect deep. And then at 1 year, you see just a little scar, no tumor, and importantly, no seizures. So I think thermal stereotactic laser ablation is just an incredible technology that is being used for more and more indications. Last year I showed, or maybe it was 2 years ago, I can't remember now, but it was hemispherectomy that I did on a little girl, and she still is seizure-free. Great result. We've done many more hemispherectomies/hemispherotomies since then with very good results. I'm not going to show any of those. I'm going to show the application of stereotactic laser ablation to corpus callosotomy. So corpus callosotomy is the disconnection of the two cerebral hemispheres, mainly indicated in the setting of tonic and atonic seizures, or quote, drop attack seizures. And this was just recently published in 2018, January, in JNS Pediatrics. And it shows the application of laser technology through the corpus callosum. The corpus callosum is a C-shaped structure, so it involves more than one laser. So you can see this one coming in from above, and this one coming in from the back, and another would come in this way and get the splenium. And so this is a slightly nuanced application of laser technology. It's a little bit complicated to get 3 lasers, or sometimes more, sometimes less, in a C-shaped structure in such a way that you can destroy that structure and not destroy anything else and not injure any of the blood vessels that are around that. But we've applied that here at Riley Hospital, and it involves a series of steps and integration of a lot of technology. This top left picture, we're putting what's called fiducials in place. These are screwed into the bone and then secured with a stitch. Then we get an O-arm spin, which is an intraoperative CT scan, where we can merge the intraoperative CT scan with these fiducials with our preoperative plan. And then we immobilize the child's head, and then I register the robot to each of those tulip head fiducials. And then we, prep and drape both the ROSA robot and the child's head. And then I move the ROSA robot to the trajectory that was planned. And because now we have registered the child's head in real time with the plan, we can accomplish a very accurate surgery. And this is an electric drill like most people have in their garage, only ours is sterile. And a depth stop, which will keep me from plunging into the brain. It will just keep me through the bone only and not through the dura in the brain. And then through a series of surgical steps, we open the dura and then put this laser catheter into the target to depth. And then at the end of this particular procedure, we have 3 lasers in place, and that's what it looks like. Then we undrape that patient and take them down to the MRI scanner, where we do basically surgery. The child in this case is in the MRI scanner. This is the user interface. And this is our fellow, Ahmed Bilal, who is toggling between thermographic imaging and anatomic imaging. And you can see along the laser trajectory, we have accomplished a thermal damage estimate, including the majority of the body of the corpus callosum. And that's the whole surgery. Then the child goes back upstairs. You remove those lasers, and then they go home the next day. It's really quite amazing application. And the seizure freedom rate is very high, on par with that for callosotomies in the open fashion, which has been done since the 40s and 50s, which is for tonic and atonic seizures, upwards of 90% seizure reduction. So very, very effective. The final thing I'll talk about, so that was resective strategies, ablative strategies, and disconnective strategies. The final thing we'll talk about is neuromodulation, which is very interesting. Neuromodulation, of course, has been going on for thousands of years. I mean, since the first doctors, Hippocrates and others, recommended standing on an electric fish to treat gout. So mostly quackery, not a whole lot of understanding of how electricity can modulate pain. However, they were on the right track. We didn't start to really apply electricity in a medical sense until Galvani and Volta, the Italian doctors, understood how to store electricity. And then you fast forward to the cottage industry of stereotaxy in humans, which was really in the 1950s, where we developed repeatable ability to place things into the brain in very specific manner. Before that, we had no ability to do that. And now we just take that for granted. We have computers and so on that help us have submillimetric accuracy within the brain, but that didn't come to be until 1950. And shortly after that, surgeons started applying electricity to stereotaxy, and boom, we come up with deep brain stimulation. And initially it was intended to treat pain, which is the most common complaint of any patient coming to see a doctor, pain for a variety of indications. And then shortly after 1960, 1965, you get Melzack and Wall, who came up with the gating theory of pain, which we all are familiar with, because whenever you stub your toe, you start to rub it, right? And when you're rubbing your toe, you can't really feel that it hurts. That is the gating theory of pain, which is the activation of A delta fibers instead of the activation of C fibers, which are pain fibers, and you trick the brain. And so the application of electricity to the central nervous system helps facilitate that and is the whole basis for spinal cord stimulation. And once we started understanding the gate theory, the Melzack and Wall gate theory as it applies to neuromodulation, we started as a discipline to we started to decrease the amount of ablative surgeries or destructive surgeries. So you see this transition from destructive surgeries that surgeons were capable of doing with increasing efficacy towards neuromodulation, where we just, instead of destroying something, we apply electricity or, importantly, medicines to modulate or change the way the central nervous system is performing. And that led to application of electricity to the spinal cord in the form of spinal cord stimulation. A lot of people think that we started stimulating the spinal cord first, but in fact we did not. Spinal cord stimulation, of course, led to FDA approval in 1989 after 22 years of study. Deep brain stimulation didn't lead to FDA approval until 95 and then 97 and then 2003, I think, for dystonia. Motor cortex stimulation is totally different and important advance, which is a strip electrode on the motor cortex, again, for the treatment of pain. And in vagus nerve stimulation, the first stimulatory approach to modulating epilepsy, FDA approved in 1997, we'll go through that. And then in 2013, responsive neurostimulation, which is the coolest so far, most complex application of electricity to modulate epilepsy. And then in 2018, FDA approval for deep brain stimulation. However, it's been used overseas and in South America and in Europe for quite some time, since 2010, which we'll go over. So our understanding of signaling processing, signal processing in the central nervous system has evolved a lot. From on the left side, the hydraulic mechanism of pain from Descartes, to the right side, where we understand that transmission of signals, including pain, but all sensory signals, start from transduction and then ultimately go to transmission and then perception. This sort of shows that on the right side of the screen, there's an ablative procedure, and on the left, neurostimulatory procedure that hopefully performs almost exactly the same thing. And this represents, both for the brain and for the spinal cord, the transition from ablative to stimulatory procedures. So in epilepsy, we really are in the era of neurostimulation. And that has started with invasive therapies like vagus nerve stimulation, deep brain stimulation, and now responsive neurostimulation, but includes non-invasive modalities as well, like repetitive transcranial magnetic stimulation and transcranial direct current stimulation. I'm not going to talk about those. They're largely research-based, although they do have variable approvals, but they are mostly research-based at this current time. We don't offer those here at Riley, although we may in the future. But I will talk about VNS, DBS, and RNS, all with the idea of modulating an epileptic network or modulating the subcortical structures, thereby desynchronizing brain function. Mechanisms of neuromodulation in epilepsy are first poorly understood and multifaceted. The stimulation parameters are all experimental, and we're missing important data, animal data, and we have limited clinical models. Electrical fields vary tremendously in the brain because of the different density of white matter. And in children, even more so because of the low water content of the brain compared to an adult brain. So children are totally different than adults in the way they respond to neuromodulation. But overall, the most important thing we lack is an ability to communicate with the central nervous system. So we have always started communicating in a tonic, square wave, on-off form, but the central nervous system probably doesn't respond to that the way it might respond to other stimulatory patterns like high frequency bursting, and other important ways of communicating with the central nervous system that are being trialed and now rolling out, particularly in the setting of spinal cord stimulation. So let's talk about vagus nerve stimulation. This is a palliative procedure, has been FDA approved since 1997, and of course it involves 2 incisions, one in the anterior neck, and one in either the subclavicular area or the axilla. I do the axilla to keep it more hidden. And then I put these in children in the subpectoral pocket, meaning I'll lift up on the pectoralis major, identify the nerve to the pectoralis medius, and then slide on top of the rib cage and place the device there, and then tunnel underneath to the anterior neck incision, where helical electrodes are wrapped around the vagus nerve. This vagus nerve stimulator is indicated in patients with intractable epilepsy who are poor candidates for basically intracranial surgery, not just resective surgery, but poor candidates for any intracranial surgery, because maybe they have diffuse epileptogenic abnormalities, or they have cryptogenic epilepsy, which really means an underlying neurogenetic problem. Or they have multiple foci and there's just no way to modulate all the foci without causing unacceptable morbidity in the form of cognitive and emotional changes. The Cochrane review has summarized VNS as effective and very well tolerated, and it truly is very well tolerated. How effective it is depends on the patient, but if you look at all comers, there's the 50-50 rule, which means that about 50% of children will have at least 50% seizure reduction. Many children have a much higher seizure freedom rate or response rate. Some children have a lower seizure freedom rate or response rate. But overall, the efficacy is the same for children and adults. Upon FDA approval, the vagus nerve stimulator was approved for children 13 years and older. Now, recently, I think 2 years ago, it was approved in children 5 years or older. As surgeons, we don't care. We just do what we want, and we can use things off-label, just like doctors use medicines off-label all the time. So we've put these in 6-month-old children who have status epilepticus or what have you. It's a very, very safe device. It is a open loop system, so it just tonically activates the vagus nerve 30 seconds every 5 minutes. It's really not very sophisticated, although the newer version, the Sentiva Model 1000, actually can sense, and I think one of the previous ones, maybe it's this Aspire, can sense ictal tachycardia. So many patients have some autonomic activation when they initially have a seizure, and it causes tachycardia, which is not physiologic, and that can be sensed by the device, and then in response to that, it will stimulate the vagus nerve, and that has been somewhat effective. It's not technically a closed loop system because it's not technically sensing seizures. It's technically sensing a physiology produced by seizures. So this is a little bit complicated of a graph. On the left, you see the y-axis indicates the responder rate and applies to the histogram. And so you can see that there is an evolution over time in the number of responders, starting out in the high 30s and ending at 2 years in the high 50s. If you follow that out further, it's in the 50s to 60s over time. You see 60% of patients will have a 50% reduction in seizure. The line with the circles is seizure freedom rate, which is only about 8% if you see on the y-axis on the right. Okay, so that y-axis applies to that line graph. And so if you're talking about what's the seizure freedom rate for vagus nerve stimulation, it's not very high, but it's a lot higher than these patients would get with any other application of another medication. The device, as we've talked about, stimulates the vagus nerve, which means that it stimulates the afferent vagal network. And the afferent vagal network is complicated. It is on the left side is 80% afferent, meaning going up towards the brain. It has at least 4 nuclei that it primarily innervates. And then after those nuclei and synapses in those nuclei, it goes through other nuclei, particularly nucleus accumbens, which is incredibly important to the desynchronization of the cerebral cortex. We know from animal models, if you lesion the nucleus, the nucleus ceruleus. If you lesion the nucleus ceruleus, those patients no longer respond to vagus nerve stimulation. Also, what we know is that time to implant matters. If you implant patients with medically refractory epilepsy before the age of 12, they have a 4% higher chance of becoming seizure-free at 10% at 2 years versus if you implant children over the age of 12, only about 6% of patients will become seizure-free. So in conclusion, for vagus nerve stimulation, it's an open loop system with tonic activation of the vagus nerve. You can activate it with a magnet, and you can turn it off with a magnet. And there are some versions of the battery that understand ictal onset and ictal tachycardia and can activate themselves, but overall it's somewhat limited. Responders increase over time. After about 4 years, there may be 60% or so of patients who have at least a 50% reduction in seizure freedom. 60% reduction in seizure frequency. However, the seizure freedom rate is very low. Of course, the device is very well tolerated. A very low infection rate really is about 2%. Patients can complain of vocal cord irritation, but overall it's pretty well tolerated. And then the vagus nerve stimulator very importantly works through the nucleus ceruleus, which is norepinephrine neuromodulation of the cerebral hemispheres. And it works by widespread subcortical targets. One of the real problems with vagus nerve stimulation is that it's $25,000 to $30,000 for the device, and then the battery wears out over time, depends on how much it's being used, but it will wear out and need to be replaced. And that a $30,000 investment in a patient who doesn't have any response is not a good investment. And so we need to try to understand who are the responders and who are not the responders. So far, there has not been any predictive mechanism to facilitate that. However, we are studying at Riley. We're one of the sub-award sites with Boston Children's and SIT Kids in Toronto and other important institutions in North America who are studying the connectomics of the ascending vagal network as it applies to the cerebral hemispheres and in the setting of vagus nerve stimulation. So hopefully with that sort of prospective registry data, we'll be able to understand more how connectomics affect seizure freedom rate or even seizure reduction rate in the setting of vagus nerve stimulation. It'd be great to just implant these devices in patients who are going to respond. Deep brain stimulation started as we talked about with trying to understand pain and the modulatory ability of the central nervous system in regard to pain. It was studied in 1954, initially for epilepsy. That, of course, is after the ability of stereotaxy in humans. A doctor named Cooper in 1970 was stimulating the cerebellum, which is very interesting philosophically because the cerebellum is not considered to be a seizure-genic area. However, his results couldn't be duplicated, and perhaps that's why we don't go after subcortical nuclei of the cerebellum. Centromedian stimulation, the CM nucleus, as well as the anterior nucleus of the thalamus. These are the two major subcortical nuclei that are stimulated in the setting of epilepsy, and both have randomized control trials showing that it is effective. Deep brain stimulation has also been applied in the setting of stimulating the hippocampus itself, the subthalamic nucleus, the caudate, and almost any other place that surgeons can place a deep brain stimulator safely. We have not yet performed deep brain stimulation for epilepsy in children. if you look in the world literature in 2018, there was a review article on the sum total of pediatric patients reported for deep brain stimulation in the setting of epilepsy. The number was 40 children. So it's not very frequently performed. It is performed in patients who have generalized onset seizures from either the temporal lobe through Pape's circuit, which was just on the previous slide, or through the frontal lobe. And usually that's the central median nucleus. This is a patient, we are capable of placing deep brain stimulators, and we have placed them for the setting of dystonia. This is a patient who had deep brain stimulators placed for dystonia. It's a very straightforward procedure. The importance of deep brain stimulation and its effect is choosing the right patient, choosing the right target, and accurately putting your deep brain stimulator there, and then programming it. And so, like I alluded to before, the programming parameters that we use to communicate with the central nervous system are largely research-based, and I completely defer to our epileptologists and movement disorder neurologists in that regard, because very complicated. It's usually trial and error. And that somewhat limits our understanding of how effective deep brain stimulation is. But in the US, among surgeons, it's been a controversial topic because the Sante trial was performed 2010, stimulation of the anterior nucleus of the thalamus for epilepsy, and it did not gain FDA approval. However, it did underlie approval in Europe and in South America, and they've been implanting deep brain electrodes in the setting of epilepsy in mostly adults since then. And their evidence is about the same for children versus adults in the setting of seizure freedom. There is a learning curve, if you will, where more and more patients who are implanted respond over time, just like in the vagus nerve stimulation. When you first put the VNS in, it's about 35% or so, and it goes up to 42%, then up to 50%, and then by year 4, you're about 60% responders. It seems to be the same with all neurostimulatory paradigms, including deep brain stimulation. But the Sante trial was the anterior nucleus of the thalamus. There was significant mistargeting. Almost 10% of patients had electrodes not in the anterior nucleus of the thalamus, so that's interesting. And at least 50% of those patients had epilepsy surgery in some other form. But there was a difference, absolute risk reduction of about 25%. That's incredible. With at 2 years, about 54% of patients achieving a seizure reduction of more than 50%. It was FDA approved in 2018 here in the States, and there are other randomized control trials showing a spectrum of improved seizure reduction or seizure freedom rates in a lot of different generalized epilepsy syndromes, including Lennox-Gastaut, which is very difficult epilepsy syndrome to treat. So conclusions for deep brain stimulation is that it was approved in Europe in 2010, and they've been implanting it. Their data for children and adults are very similar. Here it's been approved since 2018. So far, very few candidates have been implanted. However, we're looking for our first candidates here to implant. The device is expensive, like all cybernetic devices are. And the Sante trial, if you follow it out, the temporal lobe seizure patients respond best, with about 76% of them being responders. And that's really important, and that's a great result. The deep brain stimulators are also tonic activators, so they don't have the ability to sense. They're what we call an open loop system. So it doesn't sense anything, it just tonically stimulates the brain. And you can set those parameters differently, but it doesn't have any understanding of what the brain is doing. And that separates it from what we're going to talk about next, which is the coolest, most advanced way of interacting with the central nervous system that is available for clinical consumption, which is Neuropace, or responsive neurostimulation. And responsive neurostimulation is the first and only closed loop cybernetic device. It's a battery that's slightly curved. It's more complicated than a battery. It's actually the whole Bluetooth technology, and it's a generator of electricity, and can record electrograms from the from the depth electrodes or surface electrodes, whatever you choose to put in with the device. And it can learn the electrographic correlate of an individual's seizure disorder. Then once it learns that electrographic correlate, it can stimulate right away when it finds that electrographic correlate manifesting, and thus abort a seizure, a clinical seizure. And it's very effective. I'll show you the results of that. It's also, you can implant them if you're confused or you don't have enough information about where seizures are coming from. Perhaps you have, bitemporal onset and you can't do bitemporal surgery. Then you would put RNS depth electrodes in, and it will tell you over time how many seizures are coming from one side or the other. If then you find 90% of them are coming from the right, then you can do a temporal lobectomy and leave the device in the left side, for example. So it also can tell you how effective your medications are. So if you're having a certain number of seizures and you start trileptal, and then all of a sudden you can see a fall off of those seizures, and you can say, well, that was a very effective medication, you should just go up on that medication. If you start a medication, there's no effect at all on the number of seizures, you can pretty quickly get that medication off. So it's used in a variety of ways to sort of try to understand complex seizure manifestation in the brain. It was FDA approved in 2013 based on the RNS system pivotal trial, which included 191 adults. These generally do not include children. And this is FDA approved for 18 and above. Of course, we're surgeons, we do whatever we want. And so we apply this technology, very effective, very safe technology, off-label to children when they have one or two areas of seizure onset. And usually it overlaps in eloquence. So in patients who have seizure, and I'll show you a patient that we put an RNS in, if you have overlap of a patient's ability to speak, for example, with the genesis of their seizures, that tissue can't be safely removed because you will induce a dysphagia or an aphasia. And so in that context, you would neuromodulate, you would modulate that tissue instead of resecting it. And it's a lot less disruptive, and it doesn't, in between seizures, affect their ability to produce speech. So that's one of the best applications of Neuropace. There's also the quote learning curve of the cybernetic device with the central nervous system seems to work better over time. Year one, about 44% of patients are responders. Year two, 55%. And the 9-year data is upwards of 80% responders, with about a third of them being seizure free. You go back to the vagus nerve stimulator, the seizure freedom rate was about 8%. So much higher seizure freedom rate. These are much more highly selected patients, but still, it's a very good application of electricity to modulate children. This is a very short case in its presentation here, but it was actually super complicated. You can see this brain shows heterotopias here. There's septo-optic dysplasia, lack of midline structures indicating malformation of cortical development, and then also closed lip schizencephaly over here. So this is a very complex anatomical brain. We did a stereo EEG, and then after that found that the temporal lobe was the seizure genesis. We resected the temporal lobe through this perfectly square craniotomy, and then we found that there was overlap of eloquence as far as production of speech and sort of secondary seizure genesis in the schizencephalic cleft. And we put these two depth electrodes, coil the electrode under the scalp, and then this device actually goes in the skull. So we have to do a craniectomy where we remove a piece of the skull, throw it away, and then put the device instead there, and the patient's been seizure free. They actually did have a seizure, which was good because then we could turn on the device. So we knew we weren't likely to cause seizure freedom because there were two onset zones, but we decreased seizures tremendously by taking out the anterior temporal lobe, and then now we can modulate that tissue that's otherwise causing seizures, but we can't remove safely. This is a paper that I helped write on how to put these in. You can put them in a variety of ways. This is using a neck frame. which is how incidentally how we implant our deep brain stimulators here at Riley. I wrote this paper with my beloved professor Ahmed Raslan, and then also Kunal Gupta, who's a resident at OHSU and then fellow at Emory, and now is hired to start in July here at IU. So Kunal Gupta, is a very, very smart, talented, up-and-coming functional neurosurgeon who will be doing all this stuff over at Methodist Hospital. So RNS conclusions, I mean, FDA approved in children above the age of 18, but used off-label in children a lot younger. The 9-year data shows about 75% are responders, and that 30% or so are seizure-free in the long term. You can use the depth electrodes or surface electrodes, but you can only implant 2 electrodes, so that's somewhat limiting. Very low side effect profile. Battery life is a lot longer than DBS because, again, instead of tonically active all the time, day in and day out, it is active only when it identifies the electrographic correlate of a seizure. So it can last 10 years or so. The cost is more expensive, but worth it. In conclusion, for this little talk about invasive neuromodulation, basically they're all effective. They're all indicated for somewhat different patients. Closed loop, RNS is the only closed loop system and is by far the coolest system, both in its ability to help diagnose and treat epilepsy cases that otherwise are not good resective candidates. And overall neuromodulation works by myriad and incompletely understood mechanisms, which makes it great to study. In children, there are a lot of limitations. I mean, it's all off-label use. Children have different brain volumes, different myelination, different bone thickness, different vascular filling preferences. General anesthesia is different. The tissues are different. Electrical conductance is different. And they have incomplete because they're still myelinating, or totally different connectomics than adults. And all of this needs to be studied and makes this field extremely interesting. I'm finishing up here. Our epilepsy program is the only comprehensive epilepsy program in the state. We're very proud to offer every possible surgery that would be offered anywhere else in the world with good effect and very high safety margin. If anyone has any need to refer or to become involved with some of our research and stuff, you can just contact Ty at this number. You can contact me anytime at my work number or my email, which is just jraskin@iuhealth.org. I want to say one last thing about maybe in the future talking about spinal cord stimulation and collision testing. We started doing this at Riley. It's been really effective. We have published already a case report and review of the literature for spinal cord stimulation, but we're using SSEP collision testing to accurately place our electrodes anatomically under anesthesia. And it's been really effective. It's been really fun. Sarah and Haley Hill have been instrumental in helping us figure out how exactly to do that here. This is not, I mean, it's done, and it's certainly not new enough to publish in the adult literature, but maybe new enough to publish in children's literature. So I think next time, if I'm invited back to give a talk, I'd like to give a little bit of a talk about that. Maybe Sarah can join me. Anyways, I don't know who else. I'm going to end here because I'm done talking. I'll take any questions if that's a possibility.
Yeah, thank you so much, Dr. Raskin. That was a great presentation, and we will most certainly take you up on the speaking in the fall. Lisa and I will talk to you about that offline, and we'd love to have you speak for us in the fall and present again. So
Sure.
Thank you so much for joining us today. I think Lisa has a question she wants to ask. If anybody else has anything, we're allowing them to put it in the chat box, or they can just unmute again and they can ask Dr. Raskin yourself, and we can just have again an open forum before we conclude the meeting. So
Sure.
Go for it, Lisa.
All right, thank you. Thank you, Dr. Raskin, for your talk. My question is from the beginning of your presentation when you were talking about the gelastic hamartoma. Is that how you say it?
Yeah, hypothalamic hamartoma.
Yeah, so I know just from experience and when I first started studying in the field of EEG that this was kind of one of those terms that popped out to us as a popular terminology. And my question is, what exactly is a hamartoma? Can it be found in any other area of the body? And if so, why is it most commonly found in that area of the brain that causes the laughing symptoms?
Yeah, that's a good question. So hypothalamic hamartomas are, so basically a hamartoma is a non-neoplastic grouping of cells. So it's called a metaplastic group of cells. The cells are terminally differentiated. They're not neoplastic as in cancer or tumors, but they don't belong where they are, okay? And so we don't know why they're in the hypothalamus preferentially. Must have something to do with the embryogenesis of the hypothalamus in those particular patients. But they become manifest, we diagnose them because of their disruptive ability to the surrounding area. So in the hypothalamus, they disrupt whatever is going on in the hypothalamus normally to activate the fasciculus retroflexus, which presents as a seizure. When you put electrodes in a hypothalamic hamartoma, there is a tremendous amount of heterogeneity in electrical activity from just 1 millimeter away. So if you put, let's say, which people have done, 5 depth electrodes in a hypothalamic hamartoma and record from all 5 electrodes, even though anatomically they're very, very close together, maybe a millimeter separate, one will be very active and one will be totally quiescent. And that is fascinating because it speaks to this really complex presentation of a group of cells that don't belong there, aren't causing, cancer, but are causing electrical dysfunction, just like very heterogeneously. So I guess I don't have an answer to your question, why do they develop there? I don't think anyone does. You can get hamartomas all throughout the body, and you wouldn't know it unless it was causing problems. So like a hamartoma in the pancreatic head, that might cause pancreatitis, and you would find it and know it. And you can get hamartomas in the brain and tuberous sclerosis. A lot of the tubers are actually hamartomas. So tuberous sclerosis is a disease of hamartomatous production. You get hamartomas in the iris, in the brain, in the heart, in the kidneys. But we only know about them if they cause electrical dysfunction in the brain.
Very cool. Thank you so much.
Yeah, you're welcome. Thank you.
Does anybody else have any other questions you want to ask? I don't see any more questions in the chat box. Everyone is definitely thanking you and has enjoyed the meeting. So
good. Well, thanks a lot for having me. I really appreciate it. And just so everyone knows, I was wearing pants this whole time. So
nice. We appreciate that.
Yeah. Well, some people don't. So I just want to let you know I'm wearing pants.
All right. Thank you.
Okay, thanks a lot. It was a lot of fun.
Have a great day.
Good. Bye.
We're going to make some final announcements before we conclude, everyone. I just wanted to say thank you again for joining us today. I've gotten a lot of positive feedback through Facebook and on the chat box, and even private messaging me and Lisa Bose. So thank you guys for attending. Thank you to our guest speakers. Just wanted to let you know, to obtain your ISET CEUs, you will need to log into ISET's website and request your transcripts, okay, for this meeting. You will get 4 CEUs if you participated today. Just give us about 2 weeks to get that information to ISET, and then you can look for that. I also wanted to let you know that we are going to be having probably 1 to 2 webinars this summer. Lisa and I and the board have been talking about this, and we'd like to do that for you guys, all for 1-hour webinars, 2 different times this summer that you can just hop online and get a quick CEU. We'll let you know if there's going to be a cost to it. We haven't determined that yet. We're doing our very best to make things, complimentary during this pandemic that's going on right now. So more will be posted about that. And then also we are having our annual, ISET meeting on Saturday, September 26th, where you will have the opportunity to earn up to 8 CEUs. So we will have 8 speakers, 8 CEUs. We're hoping that we'll have that at that time. And again, we hope that we'll be able to have that in person. If not, we now know that we can have it via webinar virtually. And seemingly this was pretty successful today. Didn't have too many hitches or hiccups. Last, if anyone is interested in being a board member, I have to give this plug. If you are interested in being an ISET board member, please let us know. You can send us an email. You can visit our website, isetmembers.org. You can let us know. The next term will end 2021. So if you're interested, let us know. We would love for you to join our board. Anybody else have any final comments or questions? Feel free to unmute and ask us. Okay, great. Otherwise, thank you guys for attending today. I hope you have a great Saturday, and this concludes our webinar, virtual webinar.
Thank you.
Bye, everybody.